bringing together voices in child and youth healthcare. This is CAFC Presents.
CAFC would like to thank the following member organizations for their generous support of our knowledge translation activities: the IWK Health Centre, the Children's Health Foundation of London, McMaster Children's Hospital Foundation, the Children's Hospital of Eastern Ontario Research Institute, the Children's Hospital Foundation of Manitoba, the Montreal Children's Hospital Foundation, the Holland Bloorview Children's Rehabilitation Hospital Foundation, the Children's Hospital Foundation of Saskatchewan, and Trillium Health Partners. We would also like to thank the following Keystone and program partners for their ongoing contributions that support all of CAFC's programs and activities. If you have any questions or comments for our panelists, please type them into the question box at any time during the presentation. You can also share your thoughts and questions on Twitter by tagging @CAFCTweets and using the hashtag CAFCPresents. All of our webinars are recorded and can be found on the CAFC Knowledge Exchange Network. Use the CAN to share these recordings with your colleagues or register an account and post comments, links, or other resources that you think will be of interest. And be sure to sign up for the CAFC Presents weekly email newsletter to stay up to date with upcoming webinars and our recorded webinar archive. All right, hello everyone, and welcome to today's episode of CAFC Presents. I'm Doug Maynard, the Associate Director at CAFC, the Canadian Association of Paediatric Health Centers. And today we're going to be talking about pediatric donation after circulatory determination of death, PDCD, Pediatric DCD, development and implementation of Canadian guidelines. And I just realized as I was preparing for today's session that we use the acronym DCD, which we actually had a presentation on DCD a couple weeks ago, which was developmental coordination disorder. Very different DCDs. Please let's not get confused with the acronym. We are talking about donation after circulatory determination of death. And this is going to be a really interesting topic. I had a chance to meet Dr. Matthew Weiss, one of our speakers today, at our conference when we held that in Quebec City a couple of years ago, and he brought this topic to my attention. Something I was not particularly aware of, organ donation, of course, but related to brain death criteria. This is a new set of guidelines around circulatory death criteria, and we do have other colleagues from Canadian Blood Services who were part of the development of these new Canadian guidelines. So it's going to be a great presentation. We have a couple of great presenters, so it's my pleasure to introduce today's panel. As I mentioned, Dr. Matthew Weiss is a pediatric intensivist who works in Quebec City at the Centre Hospitalier Universitaire de Quebec. His interest in deceased donation began after experiencing a disappointment of a potential donor's family who were unable to pursue donation after circulatory death because his hospital was unprepared to offer their service. And since then, he has worked to develop national and local deceased donation guidelines, starting with national recommendations on how to establish pediatric DCD programs. And joining Dr. Weiss is Amber Appleby, who's the Associate Director of Deceased Donation and Transplantation at Canadian Blood Services. And she is responsible for leading and supporting national initiatives that contribute to improving deceased donation system quality and performance in Canada. So without any further ado, it's my pleasure to hand the virtual podium over to Dr. Weiss and Amber.
All right. Hey, thanks a lot, Doug. And on behalf of Canadian Blood Services, I'd like to extend my thanks to CAFC for allowing us to present. Amber, I'll just let you say hi to everybody.
Hi. I'm happy to be a part of today. Thank you very much for having us.
Great. And just before I get started, is the audio okay? Everybody hear me? All right?
Yeah, we can hear you just fine, yeah.
Yeah, let's take that as a yes. As Doug mentioned today, we're talking about PDCD and really the development and implementation of Canadian guidelines. And also, as you mentioned, this is a topic that really came to become of importance to me after a case where I was not able to offer these services and wasn't able to offer the option of donation to a family as they were losing their child, and to see how much that impacted them and how much they would have appreciated the opportunity, it really motivated me to develop a guidelines, because not only was my center not doing it, but no one in the province was doing it, and as we'll see, there was very little DCD activity in Canada at the time. So my screen to advance. There we go. So my affiliations with Canadian Blood Services and Transplant Quebec, but I have no affiliations with commercial services. And if anybody has any questions that they'd like to send me by email after this talk, please feel free. This I always put up when I talk about guideline development. I think it's important for us to keep in mind. It's a quote from a 19th century French physician. Actually, the Lyon Medical School is named after him, where he says, "Je ne soigne pas l'homme en général, mais je soigne l'individu en particulier." Just to remember that we are not treating all of humanity as physicians. We're treating the individual in front of us. And developing guidelines is a balance between making sure we give recommendations that are broad enough to help the general population will apply to the largest number of patients, while still keeping in mind that we will always have a single patient in front of us, and we need to adapt those guidelines to the particularities that he or she will have. Also, I'm not going to run through everybody here. I don't have time to thank everyone, but I just have a few slides just to show the size of this project and the number of people that were involved. You can see we had specialists from lots of different pediatric subspecialties, as well as people from nursing, bioethics, and other fields that really, so it was broad stakeholders, including some patient partners who have reviewed our guidelines, external review from an international expert, and as you can see in the top right there, some of the professional organizations that have endorsed these guidelines. So today we want to talk about the process of PDCD and why developing these guidelines were important. CPGs there is clinical practice guidelines. We want to understand the development specifically of Canadian pediatric DCD, and then Amber is really going to take the lion's share of discussing the implementation strategies at the local and national level. Just a couple definitions before we get too far into it. You're going to see on my slides, obviously we've mentioned DCD. It's been known by other names in the literature, as you see there. Pediatric DCD is just DCD in a pediatric patient, but including neonates, and that's an important thing. I'm actually, as soon as I get off this call, I'm going to be talking to my local neonatal group. NDD, neurologic determination of death, and it's often referred to as brain death. ODO, organ donation organizations such as Transplant Quebec or the many other provincial organ donation organizations. WST is withdrawal of life-sustaining therapies, which you'll see is a necessary component of DCD. Warm ischemic time is the time between when we stop treatment and when organ recovery happens. So one of the first questions that I think is kind of global in a lot of realms of medicine is, why are clinical practice guidelines important? What's the advantage here? Well, in general, one of the issues is that the publication rate of trials and medical knowledge in general continues to expand, and it's impossible for a single clinician to be aware of all the knowledge that could or should influence a decision. And then to distill that knowledge, well, you need to have a combination of clinical expertise plus the ability to critically evaluate research findings and distill that knowledge into a clinical practice guideline. Now, in deceased donation in particular, our research is spread out over a multitude of journals, and I can tell you it is quite difficult to stay on top of it. We have relevant articles that are published in critical care journals, transplantation journals, bioethics. You know, you can see organ-specific journals. I mean, I'm not going to be reading every single nephrology journal to keep up with every single advancement in potential donor management. So it's quite tough. You know, this is just pulled this off of Google search, but just shows, you know, looking in general, the number of Medline Index articles published per year. Even in 2010, we were pushing 1 million articles a year. So just the exponential rate of knowledge production and a need to distill that into something that a clinician can actually use. So besides doing that, clinical practice guidelines are also going to decrease practice variability. So, you know, an individual program is often based on local expertise and interest, and often that expertise is quite extensive, but there might be gaps, and you might not even be aware of the gaps in expertise or knowledge that your system has because you haven't had interactions with other groups. And a lack of guidance also can cause hospitals to be a little nervous around controversial programs, and which we're going to see is particularly true in this area. And so in donation, what that means is that families going through the loss of a loved one are going to have decreased access to these services. And so obviously that's going to affect the families who are not able to give organs, but it's also going to clearly affect potential recipients, and we are always in a chronic organ shortage. So how did this happen? Both, you know, I've mentioned my personal motivation, but on a systems level, we looked around as well, and we saw what was going on in the rest of the world. So in the UK, there has been over the last, you know, when I had these 7 years from 2007 to 2014, 170% increase in total DCD donation. And specifically in the 2014 report, these are pediatric, so age 0 to 17 there, where they had 33% of their organ deceased donation activity came from DCD criteria. Now, American hospitals as well have seen a large increase in both DCD and pediatric DCD activity. You can see it went from more than doubled from 66 to 134 cases in that time frame. And it is a requirement for a pediatric hospital to have at least a DCD plan in place. How are you going to deal with DCD? Either you have to have a program yourself or you have to have a plan to transfer to a facility that can provide the service. Now, that contrasts to Canadian hospitals, which in 2014 had only 8% of their pediatric deceased donation came from this pathway. And you can see these are some numbers ending in 2013, with the green line at the bottom being DCD activity, and you can see it represents a very small percentage year in, year out of total deceased donation activity. And before we started our process, these are the only two centers in Ottawa and in Toronto who had active programs, and I think CHIO at the time had done one, maybe two case. So really, almost all of the activity had come from sick kids at that point. So what's going on? Is there something specific to Canadians that might be influencing why we are slow in uptake? Well, to understand that, I think it's important to have some basic understanding of what is the difference between DCD and NDD pathways for deceased donation. And there are two fundamental differences that we're going to see in the next slide, but there's the time pressure after determination of death and when death is determined. And so, as opposed to neurologic determination of death, where the patient is determined dead in the intensive care unit, but the heart is still beating, at that point, legally, ethically, and morally, the patient is dead, but the organs are being perfused. And you have time to set up the OR. You have a controlled situation where you can go up and recover the organs without a major ischemic event. Now, in the situation of donation after circulatory death, that happens after withdrawal of therapy and after progressive hypoxia or lack of oxygen that is perfusing the organs, followed by cardiac arrest, circulatory arrest, a wait period, and then you recover the organs. And so during that time of circulatory arrest, the organs are progressively suffering from that lack of oxygen. So to balance that, the time must be short enough that the organs remain transplantable and have not suffered too much ischemic damage, but it must be long enough to make sure that death is going to remain permanent and there's no chance the heart is going to spontaneously restart. Extend those lines past organ recovery that we would be taking care of the families. But you can see one of the main differences, and I don't know if you can see my arrow here, but where death determination, as I mentioned, happens in neurologic determination of death before the patient is referred formally to the recovery center. Between these two steps is quite restricted. So with those issues in place, one of the concerns has been around that determination of death and around the is it long enough to make sure the heart isn't going to restart. There have also been people that worry about potential influence of end-of-life decision with systems or individuals having conflicts of interest to push people towards withdrawal to encourage donation. And so those ethical concerns and some logistic concerns have been voiced a lot. You know, here are just a few articles that have been published around donation after circulatory death or cardiac death, ethical issues, and one from a Canadian group that called for a full moratorium. And so, as I mentioned, there were a lot of potential concerns these groups had and did cause for a lot of publications and a lot of people to question DCD. But I can tell you that they have remained in the minority, and the majority view is, in looking at all professional society who have examined these issues, have concluded that DCD, both in adults and pediatrics, can be practiced in an ethical manner. That's not saying you don't have to be careful, you do, but it can be practiced in an ethical manner, and that includes support from, this is a publication from 2013. You can see the multiple international societies that published on this, including a pediatric subgroup, Sunny and a couple other Canadians on this group. And then here you also have the American Academy of Pediatrics has published both in 2010 and 2013 specifically on the ethics of DCD in support of it as a practice as long as there's appropriate oversight. Now, those statements were informed by ongoing scientific research in the field. Some great work coming out of Canada. This is led by Karen and Laura Hornby and Sam Shimmy on retrospective review of cases of autoresuscitation. The question is, if we don't do CPR on these patients, what has been published? How often does the heart restart? And they found no cases of autoresuscitation if there had been withdrawal without CPR. That was all retrospective, and there's an ongoing study, the DPICT and DPART, which DPICT was the pilot study, and DPART is the ongoing prospective study, that showed no autoresuscitation events after WLST past 89 seconds, and the normal wait times are longer than that. You'll see we recommended 5-minute wait times, and no cases in the few children that are included in that study. So based on these both reviews of the literature, ongoing prospective data, there's an ongoing international acceptance that DCD can be practiced without major ethical or medical concerns, with the trend being the more a center does it, the more comfortable they are with it. Canadian Environment Pre-DCD Guidelines, so as I mentioned, the governing body, the governing document of DCD at that time was the 2006 publication of DCD Guidelines, which was silent on pediatric-specific issues. It didn't say that they didn't specifically say we exclude pediatrics, but they didn't say we include them either. And they were also done in the pre-grade era, which I'm going to talk about shortly. So there was no national guidance or transparent analysis of pediatric medical or ethical concerns. Parallel to that, to us doing our work, there was a 2015 publication from an international group of organ donation physicians saying that really we need evidence-based resources to inform best practice in deceased donation for neonates and children. So, and that was, it was fortuitous that this came out because really that's what we were hoping to do. Problem is, it's hard. This is not something that can be done lightly. You need content and methodological expertise. It takes a long time to develop. We're still in the process of getting them formally published, even though the recommendations are formally finished. They're expensive. You could be $250,000. I've heard numbers in the States of people spending, $750,000 or even $1 million on these projects, depending on the size and the scope. And you require a national organizing body with appropriate mandate and resources. And really, that's where CBS came in for this project. So if we're going to develop good clinical practice guidelines, and like I said, I'm spending a lot of time focusing on how we did this rather than the content, because I assume for a lot of people that's going to be more interesting is why, how did we come to the recommendations that we did? So if you compare this, I mentioned it was actually in 2004, not 2005, the DCD Forum in Whistler. This is how I like to imagine it, is a bunch of experts sitting around the table. They got brandy snifters and cigars reading over the latest medical literature. Sam Shimmy always loves it when I show that slide, which is actually not at all how it was, but it was done before the grade era, with the grade era being a time where a process that explicitly links the evidence to the recommendations. Now, the pros of this forum that they had were that it was true expert input, and they had broad-based participation from across the country, and these were highly impactful. I mean, DCD would not exist in Canada without the outputs of that forum. The cons, though, is that they didn't have the rigorous methodology that I mentioned. There was no formal evidence assessment, and they had no mechanism for updating, which is why those recommendations are the ones we still have for both adult and pediatric DCD until the publications of our recommendations that are about to come out. So since that time, there's been an evolution in how guidelines are developed. You can see this is in the States, 2008 publication from the Institute of Medicine that had 8 standards that if you really want to have a trustworthy guideline, these are things you need to have. And so here they are, just the basics. A lot of these things make sense, but when you look at guidelines, and this is something we've done over a few projects, when you really look at international guidelines, a lot of them don't even have some of these basic things like clear declarations of potential conflicts of interest, making sure that there's broad stakeholder representation, understanding how they did their systematic reviews. So you can see it's easy to think that you've done all these things, but unless you're careful to document how they were done, it's not easy for other people to clearly evaluate the trustworthiness of your document. So for PDCD, we planned a process in line with Agree 2. Agree 2 is once again a Canadian out of the Hamilton Group method of evaluating the trustworthiness of guidelines, and we use that as a template to develop our methodology. We completed a broad scoping review on the topic. You can see here that was published in late 2015, early 2016. Then we have, there we go. We had also a forum of multidisciplinary experts, so I'm just going to go back there, to define the scope of the project, clarify the questions that required addressing. We have working groups created, and we organize ourselves into to create partnerships with professional societies. Now, at that point, we were feeling pretty good. The problem was actually applying GRADE. Now, GRADE is a great methodology. We're using it again currently on some other projects, but it was really designed to answer questions through RCT evidence, randomized control trials. It does recommend the use of best available evidence, but the evidence that we had available to us in PDCD was all of low or very low quality, and a lot of it were around questions that were better answered through qualitative data, narrative reviews, or ethical analyses, and those things did not fit cleanly into GRADE tables. A lot of them are not answerable through numbers. You're not going to tell me with numbers on whether or not it's appropriate to continue good end-of-life care with appropriate sedation after withdrawal of therapy. That's an ethical or a general good practice question. So we were in trouble, but then Bram Rochford, he came to the rescue. He's a great expert out of Hamilton, and he really helped us conceptualize how we were going to apply GRADE to our issues. He did it by showing his favorite slide, which I still find insanely complicated. Don't worry, I'm not going to go through this. It just shows how complicated the GRADE process can be, although I've grown to love this slide because it has everything on it. But we took some of those concepts and we applied established and somewhat novel GRADE concepts, including good practice statements, which I think I'm going to talk about in a moment. And we were able to take those methods and create consensus recommendations that were drafted in the working groups and approved by the Guideline Development Committee, which was the steering committee plus all the working group leads. It took some face-to-face meetings after the forum and untold hours of teleconferences, really a lot of work. I can't emphasize enough the support, the administrative support, and logistic support that CBS gave us to make that happen. So I'm just going to run through a couple recommendations, gives an idea of what they look like. So we produced 65 good practice statements. Good practice statements are statements that have univocal benefit, in our opinion, are not amenable to a typical GRADE evaluation with the GRADE tables that are more, like I mentioned, a numeric analysis of observational prospective studies. We did, though, have 7 of those recommendations available, 3 of which justified a recommendation. 4 we recommended no recommendation, meaning you could do either one or the other. And I think as important as anything in this process, we developed a list of research priorities. There remain a lot of questions in PDCD, and I think there's a lot of opportunity to answer some of the remaining questions. So this is an example of a good practice statement from our ethics section, and it is at ante-mortem interventions. So anything that any intervention you're going to be performing on a patient before the determination of death, and we recommend that they should be recognized as allowing realization of the donor or the SDM's, the surrogate decision maker's, interest and intent to donate, despite the fact that these interventions may not provide medical benefit to the potential donor. So for instance, if you give heparin, which is one of the interventions that is sometimes recommended in DCD, to a potential donor before the determination of death, that patient is not going to have any potential benefit from that heparin. You're not treating a clot in the patient. You're giving that patient heparin to prevent clots in the organ, specifically in the liver. And after an ethical analysis of these issues, we concluded that there was still, these interventions were justified if they remained low risk, if you had informed consent, and with the benefit to the patient and his or her SDMs being the ability to donate. Now, in terms of the actual interventions, so for example, we analyzed the very small amount of data there was around heparin, and we chose not to make a recommendation for universal administration of heparin. If an individual program or an individual surgeon would insist on having heparin, certainly is reasonable after discussion and consent with the family, but there is not enough data currently out there to support universal heparin administration, especially in the setting that there is some concern that you could be causing harm to the donor before the determination of death. So that's one of those situations where I think it's important to be willing to make recommendations that are somewhat neutral, even though the current practice really supports that the giving of heparin. And most physicians, although there isn't a lot of formal data on this yet, it's being developed, would generally insist on heparin being given in this setting. But we hope that this recommendation opens up the door to programs examining what their heparin practices are and what they're based in. We also recommend that regional perfusion not be used in the setting of pediatric DCD. That's a recommendation on not using regional ECMO procedures with concern over potentially reperfusing the brain. As I mentioned, the research agenda is extensive. We need a better understanding of inclusion and exclusion criteria for potential donors. We need better research into risks and benefits of antemortem treatments. As you can see, they're one of the issues that cause people to talk a lot around the ethical issues. We need a better understanding of Canadian donor potential. That's, as I mentioned, I'm going to be presenting to my neonatal group just after this call, and I'm hoping to start a retrospective review of how many patients they could have potentially had be potential donors over the last few years. And with the hopes of having a better understanding of, are we missing donors, or is it actually appropriate that there aren't a lot of donors coming out of the NICU? We need to better understand the family experience during DCD. That's unfortunately something that has been very, very poorly explored at this point, although once again, I'm glad that there is ongoing research in this field, even among Canadian researchers. So I'm happy to see already that this research agenda is being pushed into reality, and hopefully in our next iteration of these guidelines, we'll have more information to make better informed recommendations. So I'm going to have just one slide on the partners and dissemination, and then I'm going to let Amber take over. These guidelines have been officially endorsed by the Canadian Society of Transplantation, Canadian Critical Care Society, Canadian Association of Critical Care Nurses, and Canadian Paediatric Society is our publication outlet. It's been through all of their subcommittees, including bioethics and acute care, and it is with their executive committee now as a last step prior to publication. We have had patient partner approval of the guidelines. Families who have gone through the loss of a child have looked over them to make sure that we were, first of all, we're sensitive to needs of families and parents who are going through this process, and also they had some insightful comments about the language, using, for example, recovery, certainly as opposed to harvest, which is not something we would ever use at this point, but even as opposed to retrieval, and just the way that you can recover the function, recover the hope of giving life to someone else through this process. And the full report will be available on the CBS website. Several successful PDCD organ recoveries and transplantations have happened. We had our first case of multi-organ PDC recovery in May of 2016, which really was integration of multiple local services and a remote recovery team. And this really is my last slide, Amber. These are, so you can see the blue ones are still there. Those are the programs that were in existence when we started this process. The red ones are programs that are either already underway or are in development since we've started this PDCD program. So I'm really proud of that slide. I'm really glad to see we have programs developing, and there are more on the way, and following that activity is going to be an important part of our process. So Amber, I'll let you take over.
Thanks, Matt. So I'm really happy to be here today. Matt has asked me to join him to cover some of the practical considerations related to implementation of DCD And although I'm not an expert related to implementation of pediatric DCD programs, I have first-hand experience implementing a DCD program in Canada. So the first thing to really consider is the clinical environment in which you plan on implementing DCD. And likely, if you're thinking about implementing PDCD in your hospital or center, you're going to be able to draw on some previous experience from implementing NDD. However, there's a few things that are a little bit different that will impact the factors within an ICU in terms of the success of the donation process. So drawing on your experience from NDD is going to be extremely important as you think about implementing DCD in that context. One of the things in particular, and as Matt mentioned previously in the presentation, is really the challenge with respect to timing of the declaration of death. And because this is different in DCD and you require people to be there at the time of death, this may cause some challenges in terms of implementation. The process is very fast, so considerations around this would include ensuring that the area where the withdrawal takes place is in close proximity to your OR, for example, or I think in some centers they've actually looked at situations where they would withdraw in the OR setting. Family preparation is also going to be extremely key. And really in that, you're going to need to prepare the family for what to expect during the process, including preparing them for delays that might occur. It's really intensive for them, but also the fact that when DCD is about to happen, they need to have a very fast goodbye in terms of saying goodbye to their loved one and then having that process then happen and be facilitated. The other thing that you're really going to need to consider, not just within the ICU, but within your organization, is adequate preparation of your OR staff for implementation of the DCD program. And they're not used to, for example, seeing deceased donors that's without their heart beating in their ICU, in their OR. And so this is actually quite a shock to them, and it's something that you really should include them in and consider in terms of implementation. The next thing I want to talk about is just the importance of differing between roles and responsibilities in this process. It's essential that everybody knows and understands what part they play in facilitating the donation process, and that it's everybody's role is clear and transparent, and that also if there's challenges that they're not, the roles aren't blurred, for example. So we just want to make sure as you're implementing that those things are taken into consideration. The next in terms of implementation is you're going to want to explore your own ethical views on donation and transplantation. Your staff and physician views regarding that, and you're going to want to address questions and concerns openly as they arise. And one of the things that has been really helpful in implementation of adult DCD programs has been to gather various staff members and people who are going to be involved in that process and supporting that process, and having them just spend a little bit of time talking about what the differences are, meeting ahead of time, becoming a part of that implementation process. And that really helps to ensure that that process goes very smoothly. And then the last thing is that you're going to need to know where and how to find resources, both as a clinician and as an administrator. The fact that DCD in general is an infrequent occurrence and pediatric DCD even less of a frequent occurrence will mean that staff and clinicians really are not all that comfortable with it. And this could lead to anxiety, of course, within the process. And it is particularly important that this process is handled skillfully. So your clinicians who are in charge in the unit or in charge of making sure that things go smoothly are going to require some extra tools and education and support to make sure that they're tooled to do so. So next slide, Matt, if you don't mind.
Yep.
So the next thing that you're going to want to consider are really from the program administration perspective. So you're going to want to think about operational considerations, and really those fall into these 4 buckets that I've outlined here, which are infrastructure and support considerations, management of resources, looking at quality assurance and improvement, current and future activities that are needed to support these processes. And then overall, I'm just going to summarize at the end some DCD implementation considerations overall. Next slide. So in terms of infrastructure and support, what do you need? What do you have to have in advance before considering implementation of a DCD program? Well, in terms of program infrastructure, for certain, you're going to need to have policies in place And these are policies that will need to have gone through your senior executive team, through your medical leadership for approval and support. You're going to make sure that you have procedures and order sets available to guide staff. And in addition to that, you're going to want to make sure you've created, particularly in an environment where you don't do it very frequently, available checklists and educational resources for staff so that they can learn more. And in terms of program infrastructure, what also falls under this category really is bed capacity, to make sure that you have the room to do it, and also the ventilation capacity. And then looking at whether or not policies are in place in terms of life, limb, or threatened organ policies or access policies which designate a particular center as the center to which DCDs are referred, for example, or is it going to be that they are done in multiple centers throughout your province or jurisdiction? And that really does make a difference. The other thing you're going to need to do then is have agreements regarding access, timing, and with your various partners. So that could include your access or your bedline service, so that they know which center to call when they have a referral. It needs to include discussion, of course, with your partners in the emergency room to ensure that there's a mechanism for quick triage and transfer of relevant patients directly to the ICU. You don't want them staying in emerge for a long time. And you're going to have to make sure that you've addressed this as part of your ICU admission policies. If it's not there now, there certainly do need to be policies in terms of ICU admission around what happens in the case of organ donors. And last, of course, you're going to need to have some discussion with your OR staff to ensure that there is a priority rated for DCD cases. And this can be quite a bit problematic in terms of the OR and OR access, because the timeliness or the timing of the DCD is very difficult to predict. So there's going to need to be certainly some discussion and back and forth around that. And of course, last, there needs to be some staffing support for the family, and that's very important, and we'll discuss that and touch on that a little bit more in detail later. And there needs to be enough human resources at the bedside to handle a very busy assignment. So those are some of the program infrastructure considerations. I guess next I'd like to just quickly touch on some program culture considerations. There are always cultural considerations within an ICU, and I don't mean ethnic and culture considerations in terms of families, although that is extremely important. What I'm talking about here is really navigating some of the sticky business that might come up during implementation. So for example, and I may have touched on it already, really is reluctance to and timing of consulting an organ donation organization, for example. So there's a lot of debate as to whether or not you can consult your organ donation organization partners in your province too early. And I guess the advice there would really be that they're there as a resource. It's not the same as calling them to come to a unit, for example. Because of the infrequency of doing DCD and pediatric DCD, they're really there as a resource. And giving them a call to ask for help is certainly a really good practice. There may need to be a little bit of a culture change around DCD to make that sort of a priority for your unit if that's something that's not previously been done in the unit. And there's going to need to be some considerations given to staff who don't feel comfortable with it. So in the cases where you may have somebody who has some sort of conscientious objection to it, for example, you may consider changing staff assignments or handing over care from one team to another team. And this just allows the team a little bit more time to adjust. Oh, sorry, you can hear me? I must have cut out. Yeah. The next thing you're going to want to consider is whether or not there's any perceived ethical issues and how you're going to deal with those as they come up. And you really need to have an open and transparent process for addressing those. And last would be sort of the timing of DCD declaration is going to be an important consideration. So leadership, what's extremely important here is that you have invested leaders who are helping the implementation of the process. And that's really throughout the organization at all levels, from clinical staff to leadership staff within the unit to organizational staff. And really what you do need to do and foster are champions within the unit and champions that are going to move it forward. And in many centers, of course, you will be familiar with the fact that donation physicians and donation coordinators have been embedded in many programs to do just that, to help us navigate those situations. If you can advance the slide, Matt.
Yep.
So the first thing that you need to know about your logistical considerations is timing. So likely you are not going to be in the advantageous position of picking the timing of your first DCD case. Likely it's a family member that's going to pick that for you because they will be really wanting this to happen for their loved one. But you do need to first and foremost consider, is your ICU and hospital equipped to manage these type of cases? And in making this assessment, here are some of the points that you might want to consider. So you're going to think about your census and bed capacity, whether or not you have ventilation capacity. Do you want to be a referral center as you're starting out to develop the expertise and help inform policy for elsewhere within your province or jurisdiction? What are your testing capabilities? Do you have the right testing capabilities available that's required to analyze the brain death situation? And your family's willingness to transfer to another center. And this is really an important point because oftentimes this will be a primary reason why a DCD does not progress. Families will develop very trusting relationships with the staff in a center and will not often want to transfer their loved ones. So while it's certainly to our advantage in terms of consolidating resources and being more resource effective, while we may want to have sort of a referral center model, this may not always be possible, and we may actually lose cases because families really do not want to transfer loved ones to other centers. So that is an important consideration about how that's going to be managed as well. Another consideration, certainly in terms of implementing your first program, would be the availability of an on-site organ donation organization coordinator, because oftentimes they can come and provide not only support within the timing of a clinical case, but they can come and provide support for helping to develop policies, planning, procedures, checklists, and they could really be used in that way. The other thing to consider really, and this is just around referrals, some challenges that you might run into if you've got sort of an ICU to ICU transfer related to moving someone who is a potential for DCD. Historically, there may be some challenges around the perception that you're making a lateral transfer for care, and oftentimes there's just some stickiness to navigate there. And last, of course, is consideration of stability of the donor. Oftentimes it's not possible to transfer them because they're just too sick. Next slide, please. So the next thing just to consider, these are just some examples. This is by no mean, I know it's titled must have, but these are examples of the types of things that you need to have within your organization as you're thinking about implementing. And those, so in terms of policies, you're definitely going to want to have a substitute decision maker policy that's very, very clear. Your consent policies, of course, and this is no different from general ICU care. You're going to make sure that you've got for sure an NDD policy, that you have a DCD policy before you actually implement, and that you have good understanding with the coroner as to when these cases may or may not need to be reviewed, and that you've got clear admission criteria that designate the priority for admission. And then, for example, some other tools and procedures that it would be good to have in place. Oftentimes, the organ donation organization will have and will disseminate the give triggers, which really are your key to understanding what should trigger you to phone the organ donation organization with a referral. DCD checklists are very helpful, and I'll show you an example of those in a later slide. And processes such as implementing a pre-OR huddle, so everybody knows what's going to happen. You can coordinate timing, etc. And then obviously, I haven't written post-OR huddle, but that's actually equally, if not more important, how did everything go? Particularly as you're doing your first case, and a debrief after each case, particularly during the early phases of implementation. And last, of course, you're going to want to give some consideration to postmortem care. The family may want to spend some time with the body following organ retrieval. Will that be arranged so that they can spend time in the ICU? Will a bed be reserved for that? Some of the things you really want to think about. And last, you're going to want to make sure that you have resuscitation orders, comfort care orders, and donor management order sets. Next slide, please. This is just an example. It's probably hard to see, but it really just sort of provides the example that there's many things to do in this process. This is an adult example, but in process is the development of a pediatric DCD checklist. that we're hoping to develop and make available for the community as they think about implementing the DCD in their own jurisdictions. And again, there may, of course, be site-specific modifications or provincial-specific modifications that need to occur that will help this be the most relevant to clinicians, but certainly we will be working on providing this. Next slide, please. Just wanted to quickly touch on the importance of resource management. There's often a perception about the cost of doing DCD and what does this mean. So I think really the important thing to touch on is that there are various funding models for donation in various provinces. In some provinces, there are some models that include hospital reimbursement, but the important thing is that there needs not to be an impact on DCD declaration and donor management and the timeliness of donation. And the reason that I mention that is that particularly in the case of when declaration needs to happen, the way the ICU teams may be divided, if overtime is required to support continuity for family support, for example, or if it's a 2-to-1 nursing to patient assignment, there may be additional costs that are incurred as a result of providing care for a donor. The other thing that we have heard that sometimes becomes a bit of a challenge is a suggestion from our colleagues with anesthesia that there may be a little bit of concern there, perception of lost opportunity cost, as often anesthetists may not necessarily be involved in the DCD procedures. So those are just some of the fiscal resources questions or considerations. And then material resources, really, again, just sort of talking about mostly bed management and triage. How are you going to manage your existing resources that you have to make sure that this population can be accommodated? And with the low numbers that we're likely talking about in terms of pediatric DCD in particular, it's unlikely to be an issue, but in terms of overall, it could be seen as a challenge. So human resources, really, you're going to need to make sure that you've got adequate charge nurse and physicians that are supporting this process, that are available and accessible for staff. You're going to need to make sure that you anticipate and address the workload challenges with these cases. If at all possible, ensure continuity of assignments and ensure that you're coordinating staff availability. The other thing is that you can really utilize your organ donation organization personnel. That's really a key point. You need to be a partner with your organ donation organization, introduce yourself to the coordinators when they come in or evaluating a potential donor in the unit, and really help them to become a part of your team. And then ask them as well to share information and resources and work with them to help implement any changes that are required. Next slide, please, Matt. So this is by no means prescriptive in any way, just some suggestions in terms of what the ongoing quality assurance process needs to be really at the hospital, organ donation organization, or I should say provincial level, and at the system level. So at the hospital level, we've already talked about some of these cases, but these are really good practices, which is the pre-OR huddle, post-case debrief, making sure that any incidents as they come up are registered in a patient safety learning system, or that there's some sort of process to record incidents that might occur and reflect on those and review those where needed, of course, looking at root cause analysis. And that every center that is doing donation really needs to have a donation committee. And if those aren't in place, there's some good resources in some of the Accreditation Canada documents around that. That you really ought to include some of these cases, particularly if they've been challenging or it's a first case or a relatively new case in M&M rounds, that there's chart audits done as necessary. And I'll talk about accreditation in a moment because there's a bit more to discuss there. But that you're also collecting quality data and analyzing that data around your donor outcomes and looking at how you did in that process. I won't go into too much into the ODO or system level, but really suffice it to say that at the ODO level, there are a whole other set of requirements around compliance with Health Canada regulations and inspection. And they do, of course, collect their own set of data and do very extensive case reviews and have measures that they must meet to ensure the quality of organs that are delivered. And at the system level, of course, there's considerations around all of those things, accreditation, legislation, and data and analytics as well. So next slide, please. So in terms of accreditation, I think really the important thing for you to know is that there are many accreditation standards out there that deal with deceased donation and transplantation. And in particular, there are standards for deceased donors that are quite robust. But in fact, these particular standards, the very lengthy ones, are not ones that are often used or often known about. The ones that you would be familiar with, however, that are embedded within emergency department standards and critical care department standards are definitely being used within the health authorities. And just to give you an example, from 2011 to 2013, there was a survey that was done to look at and evaluate organizations across Canada that are actually using standards. And this is specific to donation and transplantation standards. And what we found was that out of the organizations that were surveyed, 11 of them were using the organ donation standards for living donors, 23 were using the complete standards for deceased donors, 20 were using the OTDT standards, which includes organ and tissue and transplant, and then 210 were using emergency department and 160 using critical care. So as you can see, it's really the standards that have been embedded regarding donation and emergency department and critical care that are the ones that people are going to be most familiar with and using. Next slide. So the opportunities really I wanted to talk to you about is increasing awareness around accreditation and accreditation standards. They are optional to use, and what I mean by optional is that the standards that are the broader set, it is really up to an organization to decide at this point in time on whether or not those will be embedded within the set of standards that they're evaluated by. So currently, as I said, I think most of the centers are using the emergency and ICU standards, and so you'll probably have copies of those and be able to have a look at what's contained within them. But there certainly is additional opportunities there to raise awareness of the other standards that are there, the broader set, which really could be a great tool for donation committees and administrators and healthcare providers in all organizations. So just the last summary slide, and then we've got some, I'm going to pass it back to Matt, and then we've got some time for questions. But really, some of the lessons learned overall, this is just, I think, a good summary slide that can be used as a quick resource in terms of implementing DCD. And again, this is experience with adult DCD. But before you start, you're going to need to identify and find some champions. Make sure you've got senior leadership support and an executive sponsor. Make sure that there are some clear expectations about who is taking DCD referrals. Is it one center or is it multiple centers? Involve your staff early and involve them in the planning, and make sure you include the education of the OR staff. Educate staff regarding differences between NDD and DCD, including some of the experience that can be gleaned from other centers who have done it so that they have some experience to draw on. And before go live, you're going to make sure that you have all of your infrastructure in place. So DCD policy and checklists, electronic order sets and guidelines. It's very helpful to do mock DCDs, particularly if you're where you're withdrawing from is not in close proximity to the OR, and establishing clear boundaries and expectations around roles and responsibilities, having a process to deal with people who aren't comfortable with that, and then having organ donation review committees. And I did put media strategy there too, and I guess it's really a question of to do or not to do. And we certainly encountered this when we rolled out adult DCD, which was, do we make a big splash and say we're doing this, or is it something that really as an organization we just need to accept as part of the care that we ought to be providing? So that's an organizational decision that you're going to need to deal with on your own. And ongoing, you're going to have ongoing education, train the trainer, you're going to need to do audits and a continuous quality assurance and improvement cycle. And then I would suggest with your first DCD, have a discussion with your first DCD family. It's important that they know that they're your first family and what's the difference between DCD and NDD. Don't alter your usual end-of-life care routines except for the specific protocols that you need to do for DCD, and ensure continuity of staff assignments for family support and staff support if at all possible, and debrief and do a quality cycle every time. And with that, Matt, I'm going to pass it back to you, and then we can take some questions.
Yeah, hey, thanks, Amber. That's as you can see, Amber has a lot of on-the-ground experience doing this both at a local level, but also being involved on the provincial and national stage. These are just some examples of KT coming up. I'm going to be presenting Grand Rounds in Saskatoon. I don't know if we got anybody from Saskatoon on the line, but I'll be seeing you in April, and also Edmonton in May. And then also we've had quite a few presentations about this, but the biggest KT stuff is going to be getting this out, it's going to be a position statement from the Canadian Paediatric Society. We're in the final stages. There's a little bit of haggling around how the word count, things like that, but it's something that they are going to be endorsing shortly and getting out there to the public. So as you can see, we have quite a bit of experience at CBA in getting these programs off the ground, both on the adult side and now a bit on the pediatric side. And we would encourage people who have questions about, look, we have some interest here, but we're not quite sure how to make this into a reality, to contact us. We have a large network of people kind of around the country who could help out and be champions, and we would be more than happy to make this a reality in your centers. Just the last slide on just the importance of guidelines and knowledge translation. This is from Atul Gawande, who I'm sure many of you have read his stuff, talking about why we fail and saying that the second reason, besides lack of knowledge, is ineptitude. That just means that the knowledge exists, but the people on the ground making that decision don't have access to that knowledge. And for the first time in human history, we're in a situation where probably if everyone had all the knowledge out there available to them, we would make a lot better decisions. And what I hope through these guideline development process and through these knowledge translation initiatives is that we make it where there's a better access of the knowledge that is necessary for clinicians to make on-the-ground decisions for their patients. So with that in mind is a picture of my kids, and I would be happy to take any questions. And you can either direct them to me or Amber or both. We'll take them no matter what.
All right. Thank you very much. Great presentation. I mean, really an interesting topic with a lot of challenges around the knowledge translation piece, getting people to understand the differences between, brain donation after brain death versus circulatory death, etc. A few of the questions that came in, and this is my reminder for the audience, if you do have any questions, we are just about out of time, but we will take a few questions if there are any others that are being typed in right now. But the questions that did come in were related to some of the things that you touched on, Amber, and please, if you do have any input, but maybe from Matt, from your perspective at a pediatric center, there was a lot of interest in how you address the knowledge piece around getting people, the clinicians who may not be, directly involved with this, to understand the difference between the brain death and the circulatory death, how ensuring that the messaging is consistent when delivering that to families, in making sure that there's not confusion, et cetera, et cetera. Just wondering your experience in addressing that. Like, again, Amber, you did talk a lot about the conscientious and all of that, but Matt, any specific experience from the pediatric center, how you went about addressing that with the clinicians, getting that broad understanding across the organization?
Sure, and thanks for anybody that sent that question in, Doug, and the rest of the attendees, because it's very important. I can give you one specific example, was our anesthesia group, and as we know, certainly in whether it's an adult or pediatric, but especially in a pediatric center, children almost never die in the OR. And so dealing with withdrawal of therapy and a death in the operating room was something that our anesthetists really, even though we had a huddle before, even though I explained what the process was going to be before, they still found it shocking personally, shocking somewhat. They hadn't really worked through the ethical concerns maybe as deeply as I thought they had. And it really was an example for me to understand the baseline assumptions that different practitioners have. As someone who works in the PICU, fortunately it's not something I do every day, but withdrawal therapy is a part of my practice. And understanding that for professionals who that's not part of their practice, they're going to need some more extensive understanding of how we do prognosis. As you mentioned, what's the difference between brain death and circulatory death? And I want to also emphasize that it wasn't just the physicians, the OR staff. There were a few that were actually quite upset by this process for a variety of reasons, some of them personal, out of our control. But it's doing, I think what was Amber really put a focus on it during the development process. Make sure you have all the professionals around. Make sure you represent to them as the process is being developed or implemented. That's the main reason I'm going to present to our NICU colleagues right now, is because I'm not sure they fully understand how the process could apply to them. And then also make sure that there's debriefing after, and there should be a debriefing on emotion, to make sure everybody emotionally is okay. I think as soon as possible, like the same night or at the latest the next morning if it's an overnight case. And then another debrief within maybe 7 to 10 days that's more focused on the logistical concerns. But just make sure that everybody is doing okay, and reaching out to them is going to be an important part. So I hope that answers this. There are a few strategies, but it really was, for our center, it was the OR team. Certainly, for the general pediatricians, it's good to know, because they're going to hear rumors about these things, even if their practice doesn't overlap with the ICU a lot. And making sure that they also understand this is a very carefully deliberated process that has strong ethical oversight, that is approved by the ethics committee, and that we are not just winging these cases. That's also something that I think is very important. Amber, anything else to add to that?
Yeah, I know we don't have much time, but what I thought was important to mention is, so Matt, I do concur with that. I think a lot of it has to do with work with staff and providing opportunities and open forums for discussion, and making sure that you provide them with the tools, guidelines, checklists. But I think one of the other things that might be helpful is that we do have additional information available for people, particularly if they have questions about some of the ethical aspects. We've just developed a donation physician ethics guide, for example, that's available on the CBS Professional Education website. So we just want to make sure that people do know that there are additional resources out there. There are certainly some ones on our website that could be helpful for people in the interim. And we'll be looking to developing more tools for people as they move forward, and certainly hearing from the community about what they are interested in and what would help and what we could help provide. We welcome that.
All right. We did have one more question that came in, I think, if we can just take this one last question, and then we'll just wrap it up with some closing comments from each of you if you have any key messages you'd like to leave the audience with. But the question that came in was probably for Amber, might be the best. You might be best to tackle this first. Just people wondering if the conversations around physician-assisted dying has had any impact on organ donation in general, as well as trying to add DCD to that conversation. Just as far as keeping clear messaging and not misconceptions around conflicts and that sort of thing. Has that conversation affected organ donation in general, and the conversation or the conversation around DCD?
Well, it's certainly a popular conversation these days, and ever since the legislation was announced, I think it's been on everybody's mind about how it may impact donation. What I can tell you is that we are actually, from a national level, in the process of creating some guidelines and recommendations to help guide professionals in this regard, but they're not exclusive to organ donation. So we really want to make sure that we're looking at it as part of the end-of-life process, not specific to donation. But certainly that's one of the things that we are working on currently and looking at those recommendations. And Matt, you may want to add in some pieces there.
Well, yeah, I think at this point, the Dodge answer I could give is that it's not legal in the pediatric population. Now, I think that there is potential that someday it will be. And I can also say that my Director of Professional Services has tasked me as the medical coordinator of donation to develop a protocol locally here. And Transplant Quebec has there's a lot of movement going on.
Sorry, you
cut out?
You cut out for about 5 seconds there.
Oh, okay. Sorry about that. I was just saying that, both so as Amber mentioned, at the national level, Transplant Quebec has developed a statement on it. I know Trillium has as well. So at all those levels, national, provincial, and local, there's analysis around these things, and I think it would be important to see what your ODO has in place first, and then to see how that might be translated into what your local situation is going to be.
And I guess the only thing I'd add there is that, the one the one piece regarding MAID, I think, is that there are very strict processes in place to ensure that the division of care is clear in those processes. So it's important to emphasize that the care teams responsible for leading that process are distinct and completely different from the care teams involved in the donation process. And I can't stress that enough. And I think also stressing the point that in Canada, and again, why we're looking at making guidelines, there needs to be a very strong process to ensure the competency of the person making the decision. And so those are all very important issues that are being explored, and they do take a little bit of time to explore to make sure that we've got we've got it right. So that's really why we're looking at the guideline development. So a little bit slower on the national level to respond to that. But certainly that's well in process, and we're expecting to have some guidelines out next year.
All right, thank you very much. And I think with that, we'll wrap this up. Is there any, first, Dr. Weiss, is there any sort of closing messages you'd like to leave the audience with? And then we'll go to Amber for this.
No, I mean, once again, I'd like to thank everybody in attendance and thank CAPC for the opportunity. And I would like to, I guess the thing to keep in mind is that as you start to look at this, it might seem overwhelming if you first just take a glance at the literature. There's a lot that's been written on DC in general, pediatrics in specific. But we worked hard to analyze it in an honest, straightforward way, and I really would encourage you to look at the scoping review and the guidelines that are soon to be published.
All right, Dr. Weiss cut out again, so we'll go over to Amber for any closing comments before we wrap up.
Yeah, thanks very much. I don't have many closing comments other than to thank you very much for having us and your time and attention. We're happy to provide any additional information that people might be interested in. So if we can come up with a way to get that back to people, that would be great. And we'll make sure that all of our information and resources are available to the audience.
And is there information on the Canadian Blood Services website for this that people could go to?
There is. All you have to do is put into Google CBS professional education and the website comes up. But yes, there's the ethics guide is there. There's our previous DCD guidelines from an adult perspective. What we haven't put on there yet are the pediatric guidelines. As Matt said, we're finishing on that publication, and soon as that publication is done, then they'll be up there as well. So in the meantime, though, there's lots there that's available, and if it's not there because we've got tools and checklists that aren't on the website, we can also provide those if we're contacted directly.
All right. Well, that sounds great. And I think with that, I think we will wrap it up. So thanks again to Dr. Weiss, if you are still there. Hopefully you are. And to Amber. Great presentation, a really controversial topic that you guys did a great job of sort of really laying it out very clear for us. And I do hope that lots of the folks out there from the institutions that are not doing DCD right now are going to at least investigate it and see if it might be appropriate for their organization. All right. So thank you very much again to the audience for joining us. We do these webinars typically every Wednesday at 11 a.m. Eastern Time. And it's great when you can watch live, as those questions really do enrich the discussion. But when you can't watch live, we do record these sessions and make them available after the fact on the Knowledge Exchange Network. Next week on March 23rd, we will have our tomorrow, it was March 23rd, we'll have our 6th and final episode of our 6-part series, Life with a Preterm Baby, that we're doing with our colleagues at the Canadian Premature Babies Foundation. This last episode is titled Starting Solids, What NICU Parents Need to Know, and they will be talking about feeding, which can be an ongoing source of stress and anxiety for NICU families long past discharge home. We'll be hearing from dietitians who will address common questions that parents have about transitioning to solid foods and what kinds of foods to begin with, signs of readiness, and how to help with how to find help with feeding issues. And once again, we'd like to thank Prolacta Bioscience for their support on that series. And then next week, we will welcome back Dr. Roberta Woodgate, who is a CIHR Research Chair in Reproductive and Child Health Services and Policy Research, to talk about patient engagement in youth mental health. She'll be talking about her study that was titled Youth Voices, Their Lives and Experiences Living with an Anxiety Disorder. So that's sure to be a great presentation next week on March 29th. So as always, some great stuff coming up. Thanks again for joining us today. Thanks again to our great presenters today as well, and we hope to see everyone back here tomorrow or next week. All right, bye.